Good morning, everybody. Where's Carolyn? There's a transcontinental internet issue. Carolyn's always here, and I'm sure she's at the other end of this, efforting vigorously to get connected. But this particular streaming platform told me that there's connection issues within this particular program. So, without further ado, I'll attempt to do this on my own. And what Carolyn and I planned for today, and as soon as she comes in, of course, I'll definitely link us up. Hopefully, they'll be able to solve these issues. And what we wanted to talk about is a question that we encounter frequently. For example, the menopause method is a way of treating women in menopause with compounded bioidentical hormones. I spend a lot of my time training and mentoring physicians and nurse practitioners and prescribing compounding pharmacists in this method. And it's rigorous. And we've been doing it so long that we've defined many steps along the way. Well, here's Carolyn Shapiro. Connection issues.
I amaze myself. Good morning. So good to see you. I'm sorry.
No, I know.
I'm late.
Why don't you carry on with the introduction? I'm glad we were able to repair these. So please tell us. Please introduce us today.
Well, you and I last week got into a discussion about breast health. And I know from talking with you so often, and I also know from so many, oh my, of the questions I get, conversations we have, it's all about the breast. I know menopause method is all about the breast. And I thought, and you had mentioned too, that we might discuss during this hour the breast, or how about both breasts, and how hormones relate to breasts, how menopause relates to breasts, what happens to breasts during menopause, and why you're so breast, you know, conscientious. How's that?
Yes, exactly.
Yeah, all right. It's a lot.
Well, when you stop and think about it, what's the bottom line in women's health, especially as it relates to the subject of hormones, and especially as it relates to the widespread disinformation about hormone and breast risk? But still, even if that disinformation weren't out there, the disinformation is that women who are treated with hormones of any kind are at greater risk for breast cancer. That's wrong. That's been disproven. It was originally wrong, even when it was put out there. And I'll get into that. But the bottom line in treating a woman of midlife is also dealing with the risk that women have for breast cancer. I mean, what could be more bottom line than that?
It is bottom line.
Yeah.
We're scared.
And that's irrespective of hormone usage or not. Of course, the science always has been and remains to this day that women who are treated with hormones are at less risk for developing breast cancer, heart attack, and stroke than women who are untreated. That's the actual science. It always was so. What came out in 2002 with the Women's Health Initiative was incorrect. Now, as far as the menopause method, and yes, the bottom line of the menopause method is be attentive to possible risks. And since this is women's medicine, we take a very strong stance around attending to breast health. And that's the subject I really want to get into. Now, this is not a unique situation for women. I mean, for one thing, as I've said many times in our interaction, Carolyn, that we're all at risk for thousands of diagnoses. Some of them are not pleasant, to say the least. And as human beings, amongst those diagnoses is we're at risk for cancers, and a lot of them. Life, that becomes more of an issue. That risk increases for cancer in general. And as a male, I'm at special risk, increased risk for prostate cancer above other cancers. Now, there's reasons for that, and they're multidimensional reasons. There's the biology of it, the emotions of it, the consciousness of it, the life practices of it, the sexuality of it. Males are at increased risk for prostate cancer for a lot of different reasons. And I'm not going to go into that because today's not about males. And women, amongst the many cancers that women can get, there's an increased risk for women to get breast cancer, and there's reasons for that. And it looks to me like over the course when I was in medical school, when breast cancer existed, but its prevalence wasn't that dominant, that
Right.
this is in, and to date myself, I was in medical school in the 60s. Breast cancer was merely another chapter in the pathology book, and it definitely didn't have the fear and the prevalence that it has these days. Why is there increased prevalence? Well, there's reasons for that. They relate to toxicity, for one thing. Most of the environmental toxins, there's so many of them, are fat soluble, and we're exposed to them. And those fat soluble toxins go into our bodies, and where do they go? They gravitate to the fat cells. And what happens if they gravitate to the fat cells of our love handles, for example? Not a technical term, but I think everyone knows exactly what I'm talking about, especially midlife.
Shall I stand up?
Shall I stand up? If it gets absorbed if these fat soluble toxins, herbicides, pesticides, these petrochemicals that are universal and the exposure has never been higher, that gets absorbed into the love handle fat cells, well, it's no big deal in the sense that there's no vulnerable tissue sitting in the love handles. Whereas the breasts, which are a high percentage of fat, that fat tissue in the breast is sitting right next to breast glandular cells, which once a month increase in number, those breast glandular cells, through cell division, a process called mitosis. A woman gets more breast glandular cells every single month if she's regularly menstruating and ovulating. And what the purpose of that is in preparation for possible breastfeeding once a month. Of course, there's
Sorry.
once a month, and the changes in the uterus are preparing a rich lining of that uterus for a possible fertilized egg to land and grow. Well, there's also changes in the breast, preparation for breastfeeding right away, every single cycle. Mitosis, cell division, is a vulnerable moment in the history of any cell. That's when the mutations can occur. It's not the only time they can occur, but that's when you don't want exposure to toxins. And that's why there's an increased risk. And it's probably related to multiple factors, including women giving their energy away in an inappropriate way. There's all kinds of reasons why we develop cancers and illnesses, but I won't go there so much. I won't dive into that unless questions pop up in our chat that any of our viewers want me to comment further about that. But I'd like to say that we're all at risk for cancers, and there is increased risk for prostate cancer and breast cancer. And that why not be vigilant? And why not do practices that don't enhance that risk? And that's, for example, why we don't like to use excessively robust or youthful levels of breast glandular cell proliferation that can be achieved by giving robust levels of estrogen to replicate youthful levels. You can get tremendous and almost all the advantages of estrogen without having to recreate a menstrual cycle and use those robust levels and put a woman at increased risk for breast cancer because you got increased mitosis. Now, there's so many causes of cancer, and cancer is such a profound illness. I'm not going to say that robust levels of estrogen are going to cause cancer. No way. Hormones don't cause cancer. There are plenty of causes, and they're not pretty. But you're never going to hear from me that hormones cause cancer. But um, there's always exceptions, by the way. There's some women who really need richer levels of estrogen treatment than the common levels of estrogen treatment, for example, that we promote in the menopause method. For example, young women vary in the amount of estrogen that they need to menstruate and be healthy. Like some women, they need this level of estrogen.
Mm.
Some women need higher levels of estrogen and do have higher levels of estrogen. Some women need lower levels of estrogen. But young, healthy women, you can't say that they need a certain amount of estrogen. They range in the amount they need. We've determined, for scientific reasons, and I explain this in the book, that optimal for menopausal women, that they can get all the health that they need in levels just below the amount needed to cause menstruation or breast glandular cell proliferation. And like I say, there are exceptions. And the exceptions really live in the community where cognition gets compromised. Most women who are in menopause and have cognitive challenge, they're not thinking clearly, they're not remembering clearly. They know it. You all know who you are. Most of these women will get restoration of really excellent cognition back to where they're totally satisfied with it by the levels that I was suggesting that occur right below young, youthful levels. Some women, not so. Some women, we really need to increase those estrogen levels, and we keep on increasing them until a woman's brain clears up. And that's a very high priority. And sometimes those levels are so robust that the period comes back. So there's exceptions to every thing in medicine you can name.
Well, you know, there are a question did just come in saying, how do we know what that level is? Do we need a blood test? Segue into what Dr.
Yes.
Rosensweet likes.
What we did, well, for one thing, in a woman that's receiving hormonal treatment, the only test, the only test that I trust 100% is the 24-hour urine hormone test. I'm not talking about the urinary 5-point where you're peeing on the filter paper. No way. I'm talking about the 24-hour urine hormone test. And what I did at one point, many, many years ago, was dive into the medical literature and correlate what's too little and what's too much. And the laboratory we use actually publishes this on the report. We know the optimal level, and too much puts a woman at risk for breast glandular cell proliferation. Too little, we're not protecting the vagina and the vagina and the bones. We know those numbers. These studies have been done, and all I did was extrapolate from the medical literature studies to define this optimal range. Sometimes we go above that optimal range, like I said, if we need to push it to get cognition to return, okay, we'll do that. Blood levels are just not useful unless you're dealing with a young, healthy woman who's regularly ovulating and has got a regular menstrual period. Then they are very useful. However, these aren't the women who are showing up to doctor's office to get tested. They're
No,
doing fine. They're not super interested in knowing their hormone levels, nor should they be.
last place they want to be.
Exactly. They have plenty of other things to do, like all of us. The ones who are young and having obviously hormonal imbalance thing, it's tough to test them because they're so erratic.
Yeah.
And so you don't know what day of their cycle to test them. But there's always ways to work with people who are having health challenges, no problem. There's always ways to work with it. Now I want to go to a more challenging topic. Dun, dun, dun.
Do I do the drum roll?
So I want to tell you about this topic. I want to sneak up on this topic by telling you a story. So early on in my 25-year specialization career of treating women in menopause with compounded bioidentical hormones, I met up with women for other reasons. I was a holistic doc at the time that had breast cancer. So they came to me because they had breast cancer, and they wondered if there was a complementary treatment to the other treatments they were getting. And what happened was I met up with actual women, actual patients. I can picture them very clearly. The first one I met up with was Elizabeth, and she was 38 and she had breast cancer. And she was seeking, again, other complementary methods to the traditional treatment she was receiving. And I did do some of those treatments with her. And eventually she passed away. So when a doctor has a patient that passes away, it's very impactful. It's not nearly so impactful on the doctor as it is the family and the people who love them. But it's extremely impactful even on the physicians themselves, as was Elizabeth's death. So I got introduced to breast cancer. I got introduced to breast cancer in medical school, but at that time it was all theory. Once you have your first patient, that's a different story. And then I treated women in a holistic way who had prior breast cancer. They received traditional treatment, and they did really well. And they were alive many years later, and they were mostly interested in their holistic health. And I remember these women. I can picture them as clearly as I can picture you, Carolyn, on this video screen. And it's a miracle when women have breast cancer and they recover and they put it in their rearview mirror and they're just interested in their health. So that's fantastic. Well, fast forward to one of the screening procedures recommended by traditional medicine is mammography. And over the years, I heard my complaints from women about mammography, especially around the compression and especially around the radiation. And so when I learned about a process called thermography that's totally non-invasive, a woman sits in front of a female thermographer who's got a heat-sensitive camera. The woman exposes her breasts, and the camera registers heat coming off the breasts, and you get quite an image there. And I got tremendously excited about it. This was in the late 1990s. And then in the year 2000, I moved to Florida and met up with my first thermographer, who was a diligent healthcare provider and did excellent work. And I got really excited. However, not so excited that I was abandoning mammography, but I was really excited about thermography. So with all the patients that I was treating, there were mandatory testing for me to be willing to treat them. And one of the mandatory tests was annual or every a couple of years or every 3 years. It always depended on the individual woman, mammography. But simultaneously, I was asking them to get thermography. Did you have a question, Carolyn? Or
No, no, I'm sort of spellbound, so I'm sorry.
okay. Uh, so here's what happened to me. And I was such a strong advocate of thermography. And one of the things that thermography registers, of course, is increased heat. And then occasionally you can see something that's abnormal, even that can suggest cancer. So 2002, one of my patients has a daughter. She's a 42-year-old vet, a holistic veterinarian, and she refers her daughter to me. Her daughter has a large breast lump. her daughter had her daughter went to get a thermogram on her own. The thermogram was negative for breast cancer. The lump kept growing, and by the time the daughter came to me, she was seeking alternative treatment for breast cancer because traditional oncologists and surgeons said it was too late to treat her. And I didn't really have that much to offer her at that late stage. And she passed away, leaving behind a 2-year-old and a 4-year-old. That was a shocker.
I, only to interject in that I'm aware of you and many of your stories of being a doctor and being on that end of it. We tend to forget that doctors have feelings too, you know? Yeah.
Yeah,
Yeah.
that was really a shocker. And it really put my first major concern about thermography. And I started investigating it, and I had a radiologist colleague who was one of the most brilliant physicians I ever met. And he told me that, yeah, you couldn't use thermography for screening, even though thermographers are mixed on this. Some of them are promoting that this is a good screening technique. Well, here's another story for you. Like I say, I was simultaneously, upon meeting a new patient, giving them a requisition for mammograms plus thermograms. I wanted to do a comparison. I wanted to find out for myself. And I had two patients. And at their annual exam, what I saw is they had thermogram reports, and they hadn't done the mammogram. And what happened is they preferred, because of their holistic orientation, to get the thermograms. And when the thermograms were negative, they decided not to get the mammograms. Well, they showed up in my office, and I was already sensitized to the possible imperfection of thermography as a cancer screening tool. It's a good tool. I'm prescribing thermograms routinely for special reasons, but not for breast cancer. So I said to these two of these women, well, for me to continue as your physician, our original agreement was you would comply with the method, and the method still calls for you to get that mammogram. So they went out and got the mammogram, and in 2 instances, these women had breast cancer. They were small. They were not detected by thermography. When a breast cancer is caught when it's small, there's almost 100% cure rate. Yeah, no one wants to go through the process of surgery, radiation, and/or chemo. And however, the cure rate is like 100%
It's worth it.
these days. And of course, when you say that, you're speaking from your heart and your experience.
100% experience. It's worth it.
Cures are great.
Yeah. Kind of
The,
sucks, but better to.
well, but to my surprise, one of those two patients was really angry with me. She said, well, you never emphasized the importance of mammogram. I don't know how much more I could have emphasized it to her. And so what I'm telling you is every physician and nurse practitioner's experiences colors their approach. And through the telling of those stories, I want you to know that the menopause method, like anyone who does the menopause method, meets up with a contract prior to doing anything. And the contract lists some of the things that the method requires, and the method requires appropriately timed mammography. And it's imperative. We simply will not embark upon the journey. I'm not trying to scare women. It's just something that we've learned over the years, that if you catch one case of breast cancer by routine mammography, and mammography is not perfect, it has false negatives. But if you catch one case of breast cancer early, it's worth it's totally worth every negative mammogram we've ever experienced.
So I want to ask you, if I may, a question. And a couple have come up on the chat too, which has now made me forget my own question. Oh, I had mammograms for 11 years. They were fine. Went to
Are
my
false negatives. The rate of false negative mammograms is low, but there's multiple ways to assess a woman, including breast self-exam, which I think is the most reliable because when you go to a provider, normal breast tissue is lumpy. It's the glands. The glands are lumpy. So when you go to a healthcare provider and they do an annual breast exam, well, they don't know your breasts and
right.
they never get to learn them.
Yes.
But what we encourage, and we describe this in the book, is a woman goes through a process of daily exam of her breasts until she knows her own lumps. Then you do weekly, then you do monthly, then you do every couple months in the shower with a little soap on your breast because your hands slide and glides easier. You get to know your own lumps. So we're not relying on one specific thing. We're relying on self breast exam plus annual mammography, and it's not perfect. But what we don't agree to is women who only want thermography. They could be perfectly right. I'm not challenging a woman or trying to scare her that if she doesn't do mammograms, that's wrong. The only thing we say is for us to be willing to be your healthcare provider, that's part of the process.
And it's a very, very important one, I believe, because it comes up all the time. I have a question here that says I have dense breast tissue and I've been told a mammogram may not show lesions, and I'm not sure what I should do.
And increased breast density is very, very common. There's
Hmm.
why it's common. And this morning, I opened up my computer to find a report of a woman that I've been following for 20 years who's had extremely dense breasts, and she just got a breast MRI. So there's a multitude of ways to assess the breasts, and that MRI really pointed out what was behind that density, and that MRI was negative. None of these screening techs are perfect, but we've come to the conclusion that there is a certain process that we go through, and it gives us the greatest possibility to uncover issues. Now, any woman who has extremely breast dense in the menopause method, that automatically triggers a new test, an additional test called thermography. Because thermography is all about measuring increased heat.
Right.
And when there's increased heat, it's usually from inflammation. And that's not a healthy situation. It's not a guarantee that you're going to get breast cancer. No way. That's the thing I don't want to plant in your mind. Something as profound as cancer in a male or a female has a multitude of causes, and that needs to be respected. But when we detect increased heat on thermography, we know that something's not quite optimal. So we take steps, and there's a chapter in the book on this, to get to optimal breast health. And for one thing, you don't want to have increased compression on healthy breasts.
Right. Are the underwire bras too?
It definitely has underwire bras, and in the book, we show thermograms, or at least we show them in the professional training. I'm not sure they're in the book. They might be. I've forgotten.
Yeah.
But you can see the difference between a woman wearing her underwire bra and the increased heat that can show up there. and her removing that underwire bra, and the increased heat disappears. And biologically, it's not that hard to understand because when you're compressing a breast, you're interfering with the lymphatic drainage, which is draining off the chemicals of metabolism that's taking place in the breast. And you can even interfere with venous outflow because venous outflow is a low pressure system. Lymphatic drainage is even lower pressure. So compression bras, sports bras, underwire bras, all of them can lead to an unhealthy breast. And there's studies, there's people who've paid a lot of attention to this. There's less incidence in breast cancer in cultures where the women do not wear bras. In
At
other words,
all, right?
at all. There's other reasons why these cultures tend to have a lower incidence of breast cancer. That's for sure. But the a bouncing breast is getting increased benefit of drainage, for example. It's healthy. So we suggest reduced bra wearing time, no underwear, no compression bras, and you can see the difference in the thermograms. So anyone who has increased breast density, we get a thermogram and we see if there's increased heat. And there's also biochemical ways to deal with increased heat, including the taking of iodine, for example. So we're a
Well,
no, we're a no breast tenderness, no um, increased heat practice. That means we do what it takes to eliminate increased heat, as reveals on mammogram or I'm sorry, on thermogram, and or any woman who has increased breast tenderness, especially women who have increased breast density, we do what it takes to eliminate the breast tenderness. And
yeah.
yet, knock on wood, we have not encountered a patient that had breast tenderness that we were not able to, a variety of measures, eliminate the breast tenderness. We are on no breast tenderness method, healthy breasts. So,
That raises, for me, if I may, a couple of questions. One that came up from Marita stating what level of density is considered very dense. I mean, is dense just dense, or are
well,
there?
they have um, they have a rating system. It's shows up on your mammogram report. It's called BIRADS, and they rate the level of density. Now, this is a good segue for me, Carolyn, to address causes of cancer,
Thank
because
you.
I don't want a woman to think because she has increased breast density that she's going to get cancer. And this is my favorite way to explain it that you and I have reviewed many times, that when a patient brings up the subject, I say, an illness so profound as cancer that can be life-threatening has a multitude of causes. And my favorite way to imagine it is, let's pretend there was a videographer who was taking a video of you from the time you were conceived. Tough to do, but doable.
Yeah, you start hiring early.
There's the first name is Lennart Neeson or something, did intrauterine
Mm.
photography. There's a book out there that shows babies at various stages. It's just absolutely phenomenal. But let's just imagine that any given woman or man had a video taken of them from the moment they were conceived and implanted in their mom's uterus till today. 24/7, you were videoed. And then let's say the videographer and their exquisite editing tools could press a button to totally edit out all the good stuff, all the healthy food that you ate, all the good exercise that you did, all the care around not getting exposed to toxic stuff, and all the excellence you developed over the course of your lifetime to deal with emotional and life stress. Notice I'm not saying eliminate the stress. This is an important part of life.
Yeah,
But
right.
I am saying that you develop skills, emotional, consciousness, mental, perception, choice skills to minimize triggering the biology of the fight or flight response, and thus to do really terrific with the stress itself and not get a huge biological response which suppresses your immune system because of the cortisol that pours out of there, etc. So let's say that videography pressed a button and got rid of all the good stuff, all the fun, all the love, all the happiness, all the success. No, they pressed a button and all that footage disappeared from the videos. What would be left behind is any time you challenged your health through inappropriate and challenging nutritional choices, any toxic exposures you had, any exercise that was excessive, because that's stressful, or insufficient, because that's stressful, big time, both of those things, and any moments where you, in meeting up with life stresses, you did an exaggerated biologically fight or flight response. Thus, that's detrimental to the immune system and your life, and so that would be left behind, and that would show us the story from conception to the moment you got the illness of how you developed the illness, whatever it is, including breast cancer. That's what causes cancer, and there's a fifth cause. The four that I mentioned were nutrition, toxicity, exercise, inappropriate exercise, and an exaggerated biological response to stress. Well, there's a fifth cause. It's mysterious. Now, there's been various theories about what I'm calling mysterious, but just to give you an example, when you see and when a woman gives birth to a child, that 3 months later that child passes away from some obscure or identifiable diagnosis, there's a lot of times you can't explain that by ordinary biological or medical reasons. They're inexplicable. And a lot of people get ill and pass away for reasons that they never discover. So there's five causes, and one of them is you can't explain it. But what I'm saying is there are causes to cancer. And when you look at any individual, when a physician or nurse practitioner takes a history and that history is detailed, you can pretty much get a picture of how they arrived at their illness. So that's how we create cancer. It's not increased breast density, although we try and address that. It's the multitude of causes that lead to illness that are really what's determining that illness. And notice I did not say that hormones were one of those causes. They are not. And those of you who want to get more in depth about this subject, Carolyn Shapiro used to go over to the house, play, at a house whose father was a world expert on breast cancer. He is an oncologist. His name is Avram Blooming. Can you imagine this? Carolyn Shapiro, his father was a friend of Dr. Blooming, and Carolyn used to go over to Dr. Blooming's house. And
we we he was very, very dear friends with my then ex-boyfriend, who's a very dear friend of mine still to this day, his father, who was an OBGYN. It's a whole thing. And I met you and realized I knew this man. And yes, I did do that. And I got to have
through
lunch.
that and was able to set up a meeting between me and Dr. Avram Blooming, who wrote the book called Estrogen Matters. And it's not the whole story of breast cancer, but here you're dealing with an oncologist who's taken this on as a specialty and is treating women who've had prior history of breast cancer, who've been,
including people that were very close to him, are very
yeah,
close.
his wife and his daughter.
You
He's
know,
treating women who've had the breast cancer properly treated with hormones. And he's the only one that I know that has an ongoing significant medical study of how are these women doing who are treated. And so Dr. Blooming's book, and Carolyn, you might as well post it again. And of course, that interview you posted on the Ins and Outs of Menopause, in which Dr. Blooming and Tavris, who are the co-authors of this book,
it is.
were interviewed by Dr. Peter Attia, who is a voice that is so wonderful out there, really promoting, really investigating and interviewing experts in all kinds of fields. And he interviewed Dr. Blooming and Dr. Tavris. But you could also, between that interview, which is available, and the book, Estrogen Matters,
It is Estrogen Matters.
if you really want to have further detail about this subject, there's the resource. Now I want to take us back. We have met up with women who signed on to the menopause method, realized that they were being asked to do a appropriately spaced and timed breast imaging study, that the foundation of which was mammogram, said yes, and then later said no. And we decided that wasn't acceptable to us, so we parted ways with these patients. And we parted ways with them in as an elegant and as kind way as possible, because I never wanted to imply to the woman that because she wouldn't get a mammogram because she didn't feel right about it, that she was doing the wrong thing for her. I just explained what I knew. I never wanted to administer, which occurs out there, as I call it, the medical curse, where some healthcare provider says something detrimental to a patient to scare them, and thus to shift responsibility is really the underlying motivation.
Yes.
So I'm never saying to a woman who's refusing mammogram that she's making a wrong choice for herself. I'm just giving her my experience, and I'm just exposing her that if we're going to be involved in treating her, the mammogram is imperative. As imperfect as it is, it's the best thing. And because I can picture Nancy and I can picture the other woman who had negative thermograms, and I can picture the veterinarian that I told you about. These are three people who had negative thermograms. In a mammography, they did, the small cancers were seen in two of those women. Those women had those treated at a very early stage. Their chances of 100% cure is extremely high. And so I wanted to give you some background of why in our method it is not optional. And there are women, in order for us to agree to treat them, mammograms are a mandatory part of our program. That doesn't make us right. That doesn't make us that women who are refusing mammograms, that they're bad, or that they're not making a wrong choice for themselves. And there are healthcare providers who will treat women who are turning down mammograms. And I'm not faulting them. I'm just telling you what our method's about. And I'm giving you background as to why we insist upon periodically spaced at the proper rate for the individual woman breast imaging techniques. That the foundation basics of it is a mammogram.
Thank you very much for, wow, it's a huge subject. When we do talk about menopause, never does it come up. Do you think that I'm going to get cancer in my, left arm? No, it's always the breast, immediately. Like,
That's fear. That's the question that comes up for women.
always.
And of course, I think you're bringing up something that we should mention. That fear did not exist prior to 2002. And prior to 2002, for example, there were 18 million women in the United States, 40% of those in menopause, who were receiving Premarin and Prempro as a treatment for menopause. It's so much so that Premarin and Prempro, and I'm not detailing what those were, but they were horse urine derived estrogens and a molecule called a progestin. They were the most profitable and popular pharmaceutical medications that ever existed up until that time. Because 100% of women go into menopause and 40% of them were receiving treatment prior to 2002. And then along
And
comes this study called the Women's Health Initiative. There was a very large and expensive study that was terribly poorly designed. Anyone who treats women would never have designed the study the way it was designed. There's so many faults to that study. But even with all the faults of that study, there was still no increased risk for breast cancer, heart attack, and stroke, even in that original study. Now you're going to say, well, what they said that there was. No. One or two of the members of that initial study committee took a look at the data. And my only strong editorial opinion is it's an opinion where they had to have some kind of misogynistic channel that they were doing. And they forced the study into publication over the objections of several members of the study committee. Why were these other members of the study committee objecting? Because the promoters of trying to publish this study, they knew that they were sitting on statistically insignificant results. They knew that Premarin itself, according to their study, horse urine-derived estrogens, 50% of which human females have never seen, were at less risk for breast cancer. In the world of science, they had a 0.79 relative risk, where one is neither increased or decreased risk. That's the number one. Well, these women had 0.79 relative risk. That means women who were treated with Premarin were at less risk for breast cancer than women who did not receive Premarin. The culprit it wasn't a culprit, was Prempro. The combination of Premarin with this progestin. Phyllis Brunson, bless her heart, is a world expert on progestin. She's a PhD and she's written about this. Her challenges to the use of progestins in general and the difficulty they've caused to women. But Premarin and Provera is the progestin, they had in the original study a 1.26 relative risk. Well, in the original study, there's a statement in there saying, but that risk is statistically insignificant. What statistical insignificance means in science is there is no proof, pro or con. It's statistically insignificant means there is no proof. So they never should have published that study because of their knowledge that it was statistically insignificant. But they published it and it spread like wildfire and it scared American women and women worldwide and American healthcare providers because they made this wild statement that was inaccurate, that there was increased risk of breast cancer, heart attack, and stroke. Well, when I read that study and my colleagues read that study, the ones that were knowledgeable, they went, why in the world did they publish that thing? This is statistically insignificant. That's junk science. They never should have done that. And look what the cause they did. 18 million women plummeted to way down to a couple million. The fallout of those women not getting treated was humongous. And that's a story for another day. What happens to women who do not take hormones? Loss of muscle, loss of bones, loss of arterial health, loss of cognition, loss of skin, loss of vagina, loss of bladder function, adult diapers, canes, walkers, wheelchairs, assisted living facilities, and nursing homes, to name a few.
I was going to say, to name a few.
Yes.
Wow.
Yes, a few, because there's other
I
consequences.
know.
Well, the cost was enormous, and that's been reported, out in scientific studies, what the cost of that was. And by 2006, because the study committee was continuing to follow up the women, they saw that the relative risk had reduced to one, which meaning there was no increased risk of Prempro. And in 2017, this original study committee published in the original journal of the American Medical Association, JAMA, that after 18 years of follow-up, there was no increased risk of breast cancer, heart attack, and stroke. That was the willingness of them to admit their the damage they had done to the American and world public. That was the level of their willingness. Well, at least they published it. But how many folks out there on the planet Earth have heard about this retraction? Very few.
And even if they do, I don't know that they quite believe it. Still,
Yeah, precisely.
you know what I
They
mean?
were so injured by that original statement and so scared by it that even those who do have read the retraction, not all women are breathing a sigh of relief. So thank you, Carolyn, for the discussion you and I had to go through this most important of topics. And Pauline is asking for the name of the book. It's called Estrogen Matters. And I'm sure I know Carolyn well enough to know that she's going to post this.
You probably, you know what I'm going to do all day. You know me that well. And I will again post it. Certainly, I will again post also the interview by Dr. Peter Attia. That's amazing. But I always have to make mention of Happy Healthy Hormones because that book I read first, and it too is excellent. Written by this guy here, and very. I think it's what in its sixth, whatever edition now. It's a great book. And having both of those books is like, you know, exponentially amazing. And you can take them with you anywhere you go and give it to any doctor. Who'll look at you like you're a little nuts, like they have time, right? Some of them will read it. I've seen it, and they've changed. So, are you still there, Dr. Rosensweet?
Yes, I am. I just got a little quiet there.
Yeah, thank you so much for I always thank you for taking this kind time, and we'll get to questions next week. But this is such a big, big subject, and that you help dispel the myths.
And it comes down to the final statement is that as human beings, this is how it began, we're all at risk for thousands of diagnoses, and we're all at risk for cancer, and we're at risk for hundreds of cancers. And as a male, because of reasons, I'm at increased risk for prostate cancer. I'm at less risk if I take testosterone, but I'm at increased risk for prostate cancer. And women, for reasons, have an increased risk for breast cancer over their relative risk for other cancers. And there's reasons why that's so. But women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who are not treated with hormones. That's what the science is. Estrogen Matters, the book, will elaborate on that and go into great depth with over 450 references to the scientific literature. It's not just an opinion piece.
No, no, it's an interesting backstory too that we don't have time to get into, but how that book was written, and Dr. Tavros too, who's brilliant as well. But please read the book, read them both. They'll be very, very helpful, I
And this
believe.
goes so far is that women who've had breast cancer and who have had that breast cancer properly treated, they happen to be at increased risk for recurrence of breast cancer as opposed to a woman who's never had breast cancer, her risk rate for developing breast cancer. However, women who've had breast cancer and have had that breast cancer properly treated are at less risk for recurrence if they're treated with hormones. That's the science. So that's really what I'd like to leave our audience with, that
Yeah.
men who are treated with testosterone are at less risk for prostate cancer, and women than men who are not treated, and women who are treated with ovarian hormones, there's four of them, estrogen, progesterone, testosterone, and DHEA, they're at less risk for breast cancer than women who are untreated. And it's the magic hour.
I always hate this time. But we will see you on Thursday, and that is fun. I will present the questions that I've put together from all of you guys. Thank you, everyone, for coming up. Thank you, Dr. Rosensweet. Always, Dr. David Rosensweet, always, for your time. So
Thank
appreciate
you,
it.
Carolyn. It's my fun, my honor, my pleasure.
It's just great to do this with you. I got
Yes,
so lucky. We all did. Yeah.
yes, I'm so grateful to you, Carolyn.
Thank you. I appreciate that. It's a
Just
nice.
think of all the times we've done this and how much fun it is and how excellent it is from my
I know,
perspective.
right? Twice
Yeah.
a week for however long. I mean, it's crazy. It's wonderful. And it's good information. And
Do you remember this, Carolyn, that we started this back when the only form of communication was carving onto rocks with
oh,
our with our flint,
yeah,
and
20
you
million
were
years ago,
interviewing me. You were interviewing me in a very limited language because there was only limited language,
I
and
was
we were
carving it in a rock,
in
whatever you
a
said.
rock. That was the question, and I would look at that rock sitting around the fire in our caves and going, "Wow, that's a good question."
It's going to take me 20 million years to figure it out, but we'll get there.
Shout out to Kim.
Yeah. Shout out really to everybody. Thank you, Krishna. Thank you, Kim and Pauline and Shane. I can't see the rest, but all of you guys rock. And
We'll see you on Thursday.
we will see you on Thursday. So, bye, everybody.